Let's begin tonight with the 29th John H.P. Maley Lecture. This lecture was established in honor of John Maley, the former president of Chattanooga Corporation, and to recognize the close relationship shared between the Chattanooga Corporation and APTA over the years. John Maley was a true friend of physical therapy, a generous supporter of the Foundation for Physical Therapy, and a strong advocate for our profession. He served as president and chair of the Foundation for the Physical Therapy from 1995 through 1999, and then 9 years as a board trustee. Over the years, the Maley Lecture have provided our profession with insight, vision, and inspiration, with each lecture adding up to the richness of each event. Let's take a moment to recognize any former Maley lecturers who may be present. If you gave a Maley lecture, would you please stand so we can recognize you? As we all realize, there's been some travel challenges this week. Unfortunately, David Maley could not be here tonight to represent the Maley family. As many of you know, the Maley family has always attended this event, and so this presence here is important. So let's take a moment to recognize the Maley family for their generous contribution to the physical therapy profession. Tonight we have the pleasure of listening to the 29th annual John H.P. Maley Lecture. In 1996, the Maley Lecture was established to honor a member of the American Physical Therapy Association who has made significant contributions to the profession, specifically in clinical practice. I am proud to introduce this year's lecturer, Dr. Phil McClure. Phil McClure is a professor and chair of the physical therapy at Arcadia University. Dr. McClure's research has included laboratory and clinical studies related to the spinal biomechanics, scapular dysfunction, rotator cuff disorders, and shoulder functional performance testing. He has authored over 20 peer-reviewed publications and several book chapters. He has received grant support from both the federal and private agencies. He has served as chair for the research committee of the APTA Academy of Orthopedic Physical Therapy and an invited expert reviewer for systematic reviews related to rotator cuff by AAOS and AHRQ. Phil has received the National Award for Excellence in Teaching from APTA Academy of Orthopedic Physical Therapy, the Bathe Carlin National Award for Excellence in Academic Teaching from APTA, and named as APTA Catherine Worthingham Fellow. His most recent award was the Paris Distinguished Service Award for sustained contributions to the APTA Academy of Orthopedic Physical Therapy, and the Career Award in Biomechanics from the Biomechanics Special Interest Group of the APTA Academy of Physical Therapy Research. Today's lecture, titled The Movement System and Diagnosis, Are We There Yet? This lecture looks at how the movement system was proposed as a foundational concept for physical therapist practice, education, and research. As many of you know, in a 2015 House of Delegates position, management of the movement system stated, APTA endorses the development of diagnostic labels and/or classification systems that reflect and contribute to the physical therapist's ability to properly and effectively manage disorders of the movement system. 9 years later, how are we doing? In this lecture, Dr. McClure will offer analysis around this question and potential pathways forward for the profession. Please join me in welcoming Dr. Phil McClure.
Thank you for that kind introduction, and good evening. I'm very grateful for this opportunity to reflect and share a perspective on what I believe is an important topic for the profession. Anyone who knows me well would confirm I tend to be a skeptic. I tend to be especially skeptical of what I perceive as lofty academic models or propositions that have little value to the clinical practice of physical therapy. After over 30 years in academia, I've seen a few of these. And when I started hearing the chatter and buzz around the movement system years ago, I must confess, I chalked this up as another useless academic ivory tower concept that really goes nowhere important. So now, after more than 10 years into this discussion, I'd like to believe I was wrong on this one. Although, to be honest, I believe the jury is still out. My goal here is to offer some key proposals that could make the movement system relevant and meaningful. Yet I'm afraid at the current moment it mostly is not. There's potential for it to go either way, in my opinion. My perspective is unavoidably tinted by my experience as an orthopedic clinician, researcher, and educator. Yet I believe these proposals apply broadly across the profession. But I'm declaring my bias up front. Hopefully my title conjures up warm memories of summer road trips with tired kids in the back seat. I'm fortunate to have experienced many of these both as a kid, a parent, and now a grandparent. As parents, my wife Kathy and I would always try to hype the trip, believing the anticipation was a huge part of the whole experience. For us, this typically meant at least 2 days of packing for fairly isolated tent camping on the islands of Lake George in New York. Food, tents, sleeping bags, the whole 9 yards. This also brought on the need to prepare and tow a boat, which was always part of the adventure. I'd like to use the metaphor of a trip to briefly look back at our history surrounding the movement system and diagnosis, and then probe the question, are we there yet? In considering that question, I started to wonder if we as a profession have even agreed on a preferred destination. At first thinking we have not. That's obviously a huge problem to a successful trip. However, after more thought, I believe the vision statement adopted by the House of Delegates in 2013, transforming society by optimizing movement to improve the human experience, is compelling, it's widely known, and it's embraced within our profession. If we accept that vision as our desired destination, I believe the debate and discussion have been about the path to get there. A suggested pathway was partially laid out in the guiding principles associated with the 2013 vision statement, and as near as I can tell, this is where the movement system was first officially proclaimed as a key component or direction for achieving the vision. Later in 2015, the development of diagnostic labels was also specifically endorsed by the House of Delegates, again as an important means towards reaching our destination. So it's these two concepts, the movement system and diagnosis, that have been at the center of our professional debates. And I would like to address each in this lecture. Despite official declarations by the House of Delegates, progress over 10 years towards true, widespread professional consensus on these topics has been slow at best. We have a long history of struggling with professional identity, but movement has historically been at our professional core. As early as 1975, Dr. Helen Hislop, in her quite elegant Macmillan Lecture, was pointing to pathokinesiology as the core science underpinning our profession. I encourage you to go back, as I did, to consider many of her concepts, as she clearly had a vision for our profession that we have, at least in part, achieved. Dr. Jules Rothstein, one of my most influential mentors, edited a special series in PTJ devoted to pathokinesiology based on an earlier symposium. Captured in the title of his editorial, Pathokinesiology, a Word for Our Times, The papers contained in that issue represent a serious debate and caution about placing all our eggs in the proverbial pathokinesiology basket. More recently, Dr. Shirley Sorman has strongly and repeatedly advocated for adoption of a movement system and associated movement system diagnoses. There have been multiple papers and editorials commenting on both the movement system and the issues related to diagnosis. My view of our current situation is that our profession is driving in circles. We have not really agreed on how to orient the map or even which map is correct. While the invention of GPS technology has greatly enhanced my own marriage, and we no longer have to unfold and refold maps and assign blame for a bad route, we're lacking GPS guidance for our professional aspirations. Our debates that seem mostly academic at this point will continue without meaningful resolution unless we gain some professional consensus on some foundational issues. So I'd like to propose some hard-earned practical guidance that I believe could help us move forward in important ways. I want to make 3 proposals and explain why I believe they are critical to forward progress. So my first proposal is that we need an operational definition of the movement system. The current definition is that movement system is the term used to represent the collection of systems, cardiovascular, pulmonary, endocrine, integumentary, nervous, and musculoskeletal, that interact to move the body or its component parts. And while I deeply appreciate the thought and debate that went into creating this initial definition, I believe it's simply too broad and vague to be meaningfully translated to education or practice. I say this from experience as we tried diligently within our entry-level program to embed this within our curriculum, and we failed. One of our senior faculty members, Kate Mangione, was a part of the initial Movement Systems Summit and Task Force. If you know Kate, you know she exudes energy and enthusiasm, and she came back from the summit insistent that we make the movement system explicit in our curriculum. I will tell you that her enthusiasm was met with confused looks and wrinkled facial expressions as we tried to translate her enthusiasm into something tangible for our curriculum. We could not, at least initially. If we look at the definition and associated models, one could easily argue that, in fact, the movement system is taught in virtually every medical school and really every health professional program that includes anatomy and systems physiology. The very first guiding principle associated with the APTA vision statement is identity. It states that the physical therapy profession will promote the movement system as the foundation for optimizing movement to improve the health of society. If the movement system is to be our unique identity, we need to create and define a truly unique system and model that can be readily understood and distinguished from the expertise of other health professionals. Guccione and colleagues have posed important challenges to the relevance of a movement system based on the current definition and model. What structure or system of the human body does the movement system exclude? What is gained by constructing an alternative and unfamiliar label to encompass all the systems of the human body? And what does such a label add scientifically and clinically to the ability of physical therapists to deliver value-based care? These are fair questions that remain unanswered. In preparing for this lecture, I informally polled as many clinicians as possible with the following question. Describe the term movement system and its relevance to clinical practice. The responses ranged from various expressions of who cares about your irrelevant ivory tower idea to vague notions of tissues and systems working together to produce movement. My personal favorite was fancy term used by seed eaters to define strengthening exercises using the kinetic chain. Suffice it to say that clinicians do not have a clear and unified understanding of the movement system. And while there are certainly exceptions, it's clear that it is not a pressing concern nor even a topic of discussion for most clinicians. However, many important ideas and changes within our profession happen at the level of professional education and then slowly work their way into clinical practice. So is the movement system being actively introduced and operationalized within our entry-level programs? The recently revised CAPTE standards and required elements for accreditation of physical therapist education programs do not contain the phrase movement system. And in fact, the word movement appears just twice in the 46-page document. In contrast, the American Council of Academic Physical Therapy, or ACAPT, adopted the following position in 2017. ACAPT endorses the concept that the movement system is core to physical therapist practice, education, and research. ACAPT therefore supports the inclusion of the movement system as 1, an identifiable element in every physical therapist educational program, and 2, a visible component of each program's public-facing web presence. Yet to my knowledge, there was not a single presentation dealing with the movement system at the last 2 educational leadership conferences, our primary national meeting related to entry-level education. The most recent data from ACAPT suggests that less than 50% of educational programs fully comply with the adopted motion, while most claim to partially comply. With the current definition, the easy thing for programs to do would be to claim simply and legitimately, we're already doing that. What curriculum doesn't review all the listed systems and talk about movement? To quote popular author and speaker Guy Kawasaki, ideas are easy, implementation is hard. There are no data on how educational programs are actually implementing the movement system and curricula, but I think it's a safe bet that there is large variation and no widely accepted standard model or approach. The primary limitation of the current definition is that it's not operational. The APA offers the following description of an operational definition: a description of something in terms of the operations, procedures, actions, or processes by which it could be observed and measured. One of my early mentors, Dr. Jules Rothstein, impressed upon me the importance of operational definitions. It was often painful at the time, but that training has served me well. He was famous for having certain words that could not be used, such as strength and tone. And he would routinely interrupt a conversation insisting on a precise, that is, operational definition. And this was because although the word implied a specific known construct, that construct could be measured or defined in many ways, and the lack of a specific meaning produced confusion and prevented serious discussion and meaningful study. So going back to my own experience as a department chair, Kate Mangione persisted with our faculty that we must embed the movement system into our program. Because we were planning substantial changes to our entry-level curriculum, several faculty members dug in and engaged in the hard work of operationalizing a model of the movement system. This took well over a year of debate and discussion by several thoughtful and experienced educators and researchers still closely tied to clinical practice. I, quite frankly, came to the discussion late and was fortunate to work with such a thoughtful group. But at the end of the day, we wanted a model that captured, as simply as possible, the very core of movement analysis and would have relevance to the training of entry-level physical therapists. The working group had educators from several specialty areas, including geriatrics, orthopedics, neurology, cardiopulmonary, and acute care. And the goal was for all of us to speak a common language across our case-driven curriculum without sacrificing the specialty content knowledge we each valued. What emerged is the four-element model of the movement system. The model proposes four basic elements required for any purposeful movement: motion, force, control, and energy. Because movement requires dynamic interaction between the person, environment, and task, the four elements are enclosed within the context of personal environmental factors. Because each of the four elements can be measured in many ways, it leads naturally to rich discussions around specific patient problems and cases. Because contextual factors can heavily influence movement and case-specific outcomes, again, the model promotes rich discussion and clinical reasoning. The model also proposes a specific and systematic framework for observational assessment of movement. Described by the acronym CAS, it calls for a qualitative assessment of control, amount, speed, symmetry, and symptoms. Qualitative observation leads to hypotheses and subsequent guided choices of quantitative tests and measures. We have used this model for over 4 years now, and at least in that period, it has stood the test of time. Other educational programs with different curricular structures have also communicated successful implementation of the model as well. It's readily applied to every one of our 20 case-driven courses covering orthopedics, neurorehabilitation, cardiopulmonary, geriatrics, and pediatrics, and is meaningfully applied by every faculty member. Our students can intelligently describe a movement system and systematically observe movement at a beginning level after 2 weeks in our program. The model is likely imperfect and could be enhanced, but it is operational across a variety of patient types and lifespan. It could be a place to start building consensus. A related point of confusion is the insistence that a movement system be defined purely physiologically. Movement obviously involves many traditional physiologic systems, but simply declaring this does not create a new system. In engineering, a system is defined as the combination of elements that function together to produce the capability required to meet a need. As just shown, we have proposed and successfully implemented a system defined by core elements of movement rather than pure physiologic systems. Another critical aspect of defining a movement system model in our professional identity is to avoid professional isolation and rather move intentionally towards collaboration. A model of the movement system should be readily understood and embraced by other health professionals. Simplicity is a necessary feature for broad adoption and implementation. If we insist on highly nuanced and physical therapist-specific jargon, at best we will be isolated, and at worst will become irrelevant. Terms such as pathokinesiology versus kinesiopathology, or detailed distinctions for 10 different labels for balance dysfunction, create barriers to collaboration on research and clinical care. There could ultimately be a place for such detailed distinctions, but only after it is proven to result in enhancing the value of care. Physical therapists do not own the movement system. We must continually earn the role as leaders and experts around movement, but we must also collaborate and utilize expertise from others. To continually earn our role as movement experts, we must lead in its study and lead in exploring the relationship between elements of movement and key problems. For example, despite extensive study, the relationship between movement and pain is still poorly understood, a point Dr. Steve George made in his 2017 Maley Lecture. Even the relationship between specific movement impairments, such as lower extremity strength and performance, is not well understood. Likewise, the science and implementation challenges around actually getting sedentary people to move and exercise will require new approaches and collaborations with experts in wellness, public health, and behavioral science. We have grown dramatically in our research capacity and sophistication over the last 30 years. In many ways, we are in fact leading as the movement experts. Yet we must continue to lead in closing the many gaps that exist in our knowledge and enhance clinical practice and move toward the vision of optimizing movement to improve the human experience. There is much work to be done, and we must be strong collaborators to make substantial progress. Our movement system model must be operational and readily understood within and by others outside the profession. So, are we there yet? I would say no, but we'll be closer when the movement system is isolated as a foundational concept or model separate from diagnostic classification schemes. This is my second proposal. In various discussions and models of the movement system, one source of confusion has been to directly link the model to a specific and standardized system of examination and intervention. This inevitably leads to a discussion of specific movement system diagnoses with associated diagnostic labels. I believe this approach of directly linking a movement system model to a diagnostic scheme is doomed to failure, particularly if attempting to create labels or categories that span all specialty areas of practice or multiple phases of the lifespan. The variety of patients and health conditions encountered by physical therapists and the specific nature of the contextual factors is simply too broad for a single comprehensive system to be meaningfully applied. Failure to isolate the movement system from diagnosis naturally leads to different movement system models. We have already seen published proposals from the Academy of Neurologic Physical Therapy and the Academy of Geriatric Physical Therapy. This is understandable and should be expected if we directly link examination and diagnosis to the movement system. If we take this route, we will necessarily develop separate movement system models for orthopedic, cardiopulmonary, pediatric, and other specialty areas. This creates confusion with other health professions and society and potentially leads to greater isolation. It certainly will not enhance and solidify our professional identity. Importantly, a hyper-focus on movement diagnoses seemingly ignores a biopsychosocial model of health and inevitably places the emphasis on the bio, even though we are learning more every day about the importance of psychosocial factors. This figure from Joel in 2017 highlights the notion that different aspects of the biopsychosocial model will vary in importance across patients, and perhaps even within a patient across time. So I believe a simpler and more straightforward approach is to isolate the movement system as a model explaining movement, period. The movement system may serve as a broad guide to examination and diagnostic schemes within rehabilitation, but it should not have the constraint of being directly linked to a diagnostic scheme. If we consider other professions associated with a physiologic system, for example, neurology or cardiology, the system does not directly dictate a particular examination or diagnostic scheme. The system rather serves as a foundation upon which to build examination and intervention approaches that necessarily vary and consider factors beyond the foundational system. Neurologists certainly consider systems and aspects of patients beyond the nervous system in their examination and diagnostic scheme, as do all other specialty areas. By isolating the movement system and the associated core elements of movement, it allows us to study movement as a defined phenomena and subsequently determine the relationship between movement and other important factors and outcomes, such as pain and functional performance. If we're honest, we have a strong bias as a profession that movement-related impairments explain more about pain, performance, and wellness than can really be supported by evidence. In education, we see this all the time in students, particularly while early in their training. They tend to automatically assume that any physical impairment is important and must be fully resolved for a patient to perceive improvement in pain or function. Experienced clinicians and researchers who have tried to prove these relationships know better. Dr. Beth Fisher, in her 2020 Maley Lecture, beautifully highlighted the idea that movement abnormalities may often be explained by a person's implicit behavioral choices to reduce risk rather than a simple physical impairment. And she illustrated this with data in patients following stroke and also in patients following ACL reconstruction who made implicit behavioral choices to move differently. My own professional research journey began many years ago with a goal to link abnormal movement to pain in patients with musculoskeletal conditions. I started with looking at lumbopelvic rhythm in people with low back pain and tight hamstrings and the effects of hamstring stretching. I subsequently moved to studying the shoulder and in particular scapular motion. We've done multiple studies using sophisticated three-dimensional motion analysis and electromyography. We've also developed and studied more simple clinical tests for scapular dyskinesis. Contrary to popular belief, scapular motion and muscle activity, at least as we have studied and measured it, does not readily explain most shoulder pain. Does this mean we should abandon analysis of scapular motion in our patients with shoulder pain? Of course not. But it does suggest that many factors beyond motion or elements of movement are likely influencing shoulder pain and disability. Likewise, it probably reflects some limitations of our measurement techniques as well as our research designs. In any case, we must have a healthy degree of intellectual humility and be fully aware of our natural biases if our goal is to provide evidence-based, high-value care. In the musculoskeletal realm, we've often chided orthopedic surgeons to treat the patient, not the X-ray, with the clear implication that the pathology identified through imaging does not capture the biopsychosocial phenomena of musculoskeletal pain and dysfunction. Is it possible that a hyperfocus on movement impairments could lead to a myopic view of a patient's health condition, where we fail to consider the whole biopsychosocial picture of the patient? Let's not let a hyperfocus on movement become our X-ray. I believe movement is and should remain our core expertise. We have ample evidence that movement is critical to health and well-being. So study and expertise of a movement system is an excellent fit for our profession. However, I strongly advocate separating our model and definition of the movement system from premature adoption of systems of standardized examination and associated diagnostic labels and corresponding interventions. We simply are not there yet, and failure to separate the movement system from specific classification schemes will keep us riding in circles rather than moving forward. So are we there yet? My answer will be yes, when clinical scientists develop and test diagnostic classification systems that guide decision-making for the movement system. This is my third proposal. The work of developing meaningful diagnostic classification systems must be done by clinical scientists performing appropriate research, guided by sound theoretical constructs. There are no shortcuts. To be meaningful, diagnostic schemes with associated tests and measures should be tested for reliability and ultimately demonstrate validity. And at the risk of stepping on some toes, I believe at times we've gotten this wrong by trying to utilize administrative and political processes to adopt or endorse a diagnostic scheme before these scientific steps have been completed. These attempts will ultimately fail if not supported by rigorous research documenting both reliability and validity for the process of classification and matching interventions. With that said, I believe our professional organizations, and particularly our specialty academies, can play a role in facilitating appropriate research. And I can illustrate this process with an example from my own experience. When the orthopedic section, now the Academy of Orthopedic Physical Therapy, decided to facilitate development of a clinical practice guideline somewhere around 2008, I had the opportunity to lead the initial shoulder guideline group. The group was a combination of academics and full-time clinicians, all with significant clinical experience and a publication history related to the shoulder. After several years of review work and meetings, we published a guideline in 2013 focused on adhesive capsulitis. Aside from evaluating and summarizing the available evidence, which was the main charge of the group, we collectively realized there was no published framework that guided specific clinical reasoning or classification for rehabilitation of the condition. So despite the lack of evidence, this group proposed a scheme based on the concept of irritability. Because we believed the scheme was important yet somewhat buried within the guideline, Dr. Maley Lecture and I decided to publish the scheme with a broader perspective. We proposed what we called the Staged Algorithm for Rehabilitation, or the STAR shoulder, in 2015, hoping it would spur the necessary research. Since that time, multiple case series have been published using the scheme, as well as one study demonstrating reliability of therapists to classify a broad group of patients across a large clinical network. Very recently, we have published work led by Laura Pachun, performed within a large clinical system that begins to validate the scheme. In a large network of therapists treating outpatients with shoulder conditions, she was able to carefully compare outcomes in patients receiving matched care according to the scheme with those receiving unmatched care. Her data clearly showed that matched care consistently outperformed unmatched care. So after 10+ years, we have beginning support for this approach with much work left to be done. My point in sharing this story is that the AOPT facilitated this process by supporting the guideline group. Without that initial group collectively realizing we lacked a scheme to guide classification and clinical reasoning, none of the subsequent work would have happened. In this case, the support was somewhat accidental. But imagine if specialty academies set out intentionally to support development and research around classification and diagnostic schemes. So what could intentional support look like? What neurology and geriatrics have done is appoint task forces to develop proposals and schemes. This is exciting and may be a good approach. This could allow clinical research groups a strong starting point for studies. Another option could be to develop funding mechanisms, either within academies or in collaboration with the foundation, to support clinical research focused on classification in research groups where there is already strong infrastructure. However, based on my own experience, my strong suggestion would be to assure that such groups are multidisciplinary and include people that have experience with implementation. In the Pachun study quoted earlier, we were essentially unable to change the degree of matched care, i.e. therapist behavior, through training, despite an extremely simple and intuitive scheme. This failure of implementation occurred in a system where the clinical leadership strongly promoted and supported the training of clinicians and the overall implementation of the model. So again, ideas are easy, implementation is hard. The more we can start the process with a clear and realistic view of what might be ultimately successfully implemented, the process could become more efficient and scalable. But our diagnosis and associated labels really are a big problem. Diagnostic labels are typically just a necessary method of shorthand communication for broad healthcare record keeping and perhaps epidemiologic or health systems type research. Do clinicians really rely on a diagnostic label to guide specific management of a patient? Capturing all relevant biopsychosocial aspects of a patient's health condition in a single label seems somewhat of a fool's errand. I would posit that effective and experienced clinicians, both physicians and therapists, would readily acknowledge that they consider many patient-specific factors not captured by a label to guide specific interventions. At least I hope so. Perhaps more critical to our survival and growth is to clearly understand and then communicate effectively which patients we are most likely to help. Said differently, where exactly do we offer the most value in the system? Although I strongly commend the APTA's recent efforts to communicate our value for several health conditions, we have not studied or communicated this well in any systematic fashion. I had occasion to interact with a family physician at a party recently, and he quite curiously asked me, "What sort of patients should I send to PT?" At first, I wanted to say, well, of course, the ones that will get better with PT. But I confess that my real answer was less than eloquent, and I rambled something about patients with pain or movement problems causing significant limitations in their activities. Imagine if we had a clear, systematic understanding of that issue. There are two examples that I'm aware of that illustrate development of guides in directing care at the primary care level. The first is the start-back stratification approach to managing low back pain. Though imperfect and with mixed evidence for actually guiding care, this prognostic approach uses a simple screening tool to identify patients at different risk levels for chronicity based on physical and psychologic characteristics. Supervised physical therapist care is only recommended for moderate or high risk levels, while patients at low risk are simply given basic advice and reassurance. A different example comes from the American College of Radiology to guide the use of referral for imaging procedures. They have developed an extensive array of appropriateness criteria, readily accessible online, to assist primary care providers and others in decisions regarding referral for imaging. This approach involves creating a limited number of clinical scenarios, known as variants, around a broadly defined condition such as shoulder pain. The clinician can then match their patient to a specific variant and make an appropriate choice regarding imaging referral. Imagine if we had a set of appropriateness criteria to guide which patients should get referral to physical therapy and broadly what sorts of interventions were indicated. Some may argue that our clinical practice guidelines provide this information, yet the structure and nature of our CPGs make it unlikely for anyone outside the profession to access or use the information for the purpose of referral. A glaring example of the confusion surrounding which patients get referred to physical therapy is the unwarranted variation in referral for low back pain. We've celebrated several studies showing that early use of physical therapy leads to lower use of costly and harmful procedures such as advanced imaging, surgery, and opioid medication in patients with back pain. Yet these and other studies have highlighted the fact that typically less than 10% of patients seeking medical care with low back pain see a physical therapist. Is 10% the correct rate? And if so, are we seeing the correct 10%? We really have no idea, and we assume we can help everybody. These studies have generally been in patients covered by commercial or military insurance. Other data shows that in patients with low back pain being covered by workers' compensation, over 50% of patients see a physical therapist. Without knowing which patients we are likely to help, we should expect this extreme variation. And while there may be important differences between work injuries and other causes of low back pain, there can be no real defense of that tremendous variation in referral for low back pain. Development of clear guides for appropriate referral to physical therapy would be a huge achievement. If it were developed by a multidisciplinary group in a way that could be defended and realistically accessed and implemented on a broad scale, it would provide a significant step forward towards value-based care. As a profession, we obviously have many big challenges ahead of us. We exist within an often dysfunctional healthcare system that is struggling to incentivize value-based care, and therefore our services are often over or underutilized because of misaligned incentives. Our reimbursements are often inadequate, and our professional education costs too much. However, there's reason for optimism. Our research capacity and the scientific underpinnings of our practice are stronger than they have ever been. Our primary tools of exercise, manual or hands-on therapy, and education based on proper therapeutic alliance and cognitive framing all have strong evidence. We offer outstanding value that is slowly becoming recognized, but we have a long way to go toward achieving our vision. We are not there yet. Before I close, I want to share an excerpt from Dr. Jules Rothstein's 1986 editorial introduction to the special issue dedicated to pathokinesiology that seems fitting. He's reflecting on Dr. Helen Hislop's not-so-impossible dream vision laid out roughly 10 years earlier. He says, 10 years later, we still may be inspired to believe all things are possible. But how can we dream together when visions are divergent? How can we follow a vision when we do not know what it is? We must realize that our collective task as members of a great profession is to identify those with the visions worth following so that we might be a profession with a face to the world rather than a consortium of practitioners loosely tied together by historical accidents. Reaching professional consensus on a clear and operational definition of the movement system would allow us to move forward in promoting our identity as movement experts. Isolating the movement system as a foundational model apart from specific examination or diagnostic schemes will bring clarity to our core identity and expertise. We do not own the movement system, but we should lead in its study. We must recognize the other expertise and promote collaboration to better understand how movement fits into overall health and well-being. Separating the movement system as a foundational entity will also allow our clinical research enterprise to more readily develop and ultimately validate meaningful diagnostic classification schemes. Our specialty academies can play a role in facilitating the work, but we must not try to shortcut the necessary research or substitute that research with administrative process. We're doing good work, but much work remains to be done. Working harder without a focused and unified approach will delay progress. I remain hopeful that our debates about a movement system and diagnosis can lead to consensus regarding the path toward the worthy destination of optimizing movement to improve the human experience. So as I close, I'd like to acknowledge many folks who provided feedback, insight, and editorial help as I've developed the ideas presented here. I am so grateful for the gift of professional colleagues who make going to work so much better. And finally, I'd like to acknowledge my lovely wife, Kathy. She is my best friend and gives her unwavering support of almost anything I pursue. Thank you.
Thank you.
Do I step off now,
Yes.
or do I
Yeah,
stay
you can go
up
back
here?
this door.
Okay.
Dr. McClure, thank you for an amazing lecture. Please join me in another round of applause for Dr. McClure.